Hello everyone, this is Mrs. Correa. Welcome to week 10 lecture. We'll be discussing about children with respiratory conditions and ENT conditions and children with gastrointestinal conditions. Under the respiratory and ENT conditions, there are so many disease conditions in pediatrics, but for the purpose of this class, we are going to discuss on esophageal atresia and tracheoesophageal fistula, cystic fibrosis, otitis media, and CROP. All the other conditions, many of them you have learned in your 112 and 213 classes, and we don't want to repeat the same thing. But it is good to read the pediatric content of those in the textbook. But for a 3-credit class, we are unable to cover all the topics in our ward and his list. So I have condensed and picked up some few topics which is really relevant and which is very common in pediatrics. Starting with esophageal atresia or tracheoesophageal fistula, it is the failure of the esophagus to develop a continuous passage, and it is commonly seen with polyhydramnios. Here, the proximal and or the distal portions of the esophagus may or may not be connected to the trachea by a fistula. So these pictures are the different variations you will see with the tracheoesophageal fistula and esophageal atresia. So I just want you to pay attention to these pictures. For the purpose of exam, we are going to focus more on the signs and symptoms and the nursing management. We are not going to focus much on the pathophysiology for the exam purpose. The signs and symptoms of esophageal atresia and tracheoesophageal fistula are excessive drooling and secretions, frothing and bubbling at mouth and nose, cyanosis, respiratory distress, choking with attempted feeding, maternal history of polyhydramnios, and when feeding, symptoms may intensify and lead to regurgitation, choking, and aspiration. Tracheoesophageal fistula is managed by surgical corrections, so we do not feed the baby before surgical correction. Remember that, because if you feed with the fistula, it will go directly into the lungs and that can cause pneumonia. So nursing care involves preoperative care, that is intravenous feedings, and infant positioned at 30 to 45 degree elevation of head with head turned sideways, because there is so much oral secretions and you don't want those secretions to be entering into the lungs. So that is why, like when you put the baby's head sideways, the secretions can drool down sideways. And suction at frequent intervals, monitor fluid and electrolyte balance. And post-operative care includes monitor vital signs at regular intervals, avoid dislodging of any chest tubes still present. Education and discharge instructions include instruct on wound care and prevention of infection, tell parents to report any difficulty in swallowing, instruct on positioning to avoid aspiration, educate on signs of respiratory infections and of a stricture. The stricture may be demonstrated by refusal to eat, and we have to monitor for that too. Next topic is cystic fibrosis. It is an inherited autosomal recessive disorder which causes production of thick mucus that blocks exocrine glands and affects several body systems including respiratory, gastrointestinal, and reproductive. Most common cause of chronic respiratory disease in children is cystic fibrosis. One of the most common cause. The signs and symptoms, as I mentioned already, it is a multi-system disease. It all affects almost all the system. And the symptoms present according to the body systems affected. The gastrointestinal tract symptoms will be meconium ileus, which is failure to pass meconium in the newborn period, prolonged jaundice, steatorrhea, and rectal prolapse. Respiratory symptoms are crackles, wheezes, diminished breath sounds, dry productive cough, tachypnea, hypoxia, and cyanosis. Integumentary symptoms are salty tasting, tears, and skin. Why is that? The CFTR protein, that is the cystic fibrosis transmembrane conductor regulator protein, normally regulates the chloride channel and facilitates the activity of other chloride and sodium channels at the cell surface. So always the sodium and chloride goes together. That is why when that channel is disturbed, you will see salt tasting, tears, and skin, and this is especially found in cystic fibrosis. Secondary consequences include dehydration, malnutrition, intestinal atresia, idiopathic pancreatitis, biliary cirrhosis, cholestasis, emphysema and atelectasis, prolonged hypoxia, hemoptysis, bacterial pneumonia, diabetes, anemia, failure to thrive, and osteoporosis. The common physical features you will see in cystic fibrosis are thin and underweight, classified as less than 10th percentile for height and weight on a standardized growth chart, barrel chest, protuberant abdomen and distension, wasted buttocks, thin extremities, listlessness and lethargy, delayed development of secondary sex characteristics and infertility, and occlusion of vas difference in males or of the ovarian ducts in females. The diagnosis is based on positive family history of cystic fibrosis, absence of pancreatic enzymes, increased electrolyte concentration of sweat, quantitative sweat chloride test, that is the common one used as a diagnostic test, chronic pulmonary involvement, chest X-ray films show patchy atelectasis and obstructive emphysema. Nursing care include ensure respiratory function by controlling infection and improving aeration, enhance nutrition through diet and enzyme replacement, promote growth and development, encourage independence for both patient and family. The education and discharge instructions include teach the family about the nature of the disease, about preferred meal plans, high caloric diet, and mixing pancreatic enzyme with meal, how to manage day-to-day minor complaints, how to administer medications properly, to monitor child's weight, to ensure proper growth patterns, to do respiratory therapy before a meal, as chest physiotherapy may induce vomiting of the thick tenacious mucus. Croup, otherwise known as laryngotracheobronchitis. I want you to learn croup from this PowerPoint, not from the textbook, because the way it is explained is a combination of many conditions. That is not how I want you to learn. So I have prepared the slides on croup for you and learn from this PowerPoint. So it is an acute inflammatory disease of the upper airway and larynx caused by a viral infection. It is a generic term for a heterogeneous group of illnesses affecting larynx, trachea, and bronchi. The lateral walls of the trachea below the level of vocal cords are marked by swelling and erythema in this condition. The etiology is usually viral, caused by parainfluenza virus, that is the most common cause, then rhinoenterovirus and adenovirus, RSV, influenza type A and B. The bacterial croup is usually caused by Staphylococcus aureus. It is most common among the age group between the age of 6 months to 6 years, and it is peaked during fall and winter. Signs and symptoms, URI symptoms, rhinitis for 3 to 4 days, sore throat, rapid onset of characteristic brassy barking cough, and that is the hallmark. And you will see this children coming to the doctor's office with a barking cough, and as soon as you hear that, you will be like, okay, it is croup. Then inspiratory stridor, hoarseness, fever usually absent or low grade, and it can be high grade occasionally. Symptoms worse at night, symptoms increase with agitation or crying, mild stridor there is no stridor at rest, and moderate if stridor persists when at rest, and severe when retractions and cyanosis, dyspnea, and expiratory stridor present. The diagnosis is based on clinical signs and symptoms. Typically, like I said, when the child comes with a barking cough, and the mother will say, "I just started yesterday night, it's like a barking cough," and you want to listen to that, then yes, then you will say, okay, this is croup. And as well as the history, like usually the parents explain. The diagnostic tests are not usually done on this because the diagnosis is based on clinical signs and symptoms. And if severe presentation, you should do pulse oximetry because hypoxia indicates severe disease. Then soft tissue imaging of the neck and chest shows classic steeple sign. WBCs may be normal or elevated, and this is also, all these tests are not usually done. The management includes, in mild disease, promote rest, administer medications as prescribed such as antipyretics, provide humidification, but there is no evidence to support the use of mist therapy, but it is often still used since it is harmless and some patients find it soothing. Moderate to severe disease, airway maintenance is first priority. You may have to hospitalize for supportive care and oxygen. Monitor fluid balance and IV fluids need to be given. Observe for changes in level of consciousness. And medications used are corticosteroids. It is indicated for almost all children regardless of the severity. You may see some providers may not prescribe, but it is also a common practice that you will use corticosteroids for croup, and it lessens the severity and duration of the symptoms. Moderate to severe croup, you may see using nebulized racemic or L-epinephrine, and if you use those medications like nebulized racemic epinephrine, you have to observe for another 3 hours after a dose for rebound respiratory distress. Then antibiotics are not usually indicated unless a bacterial infection is present. Education and discharge instructions. Instruct on use of cool mist humidification or steamy bathroom. Like I said before, the evidence does not support, but you will see most parents will tell you that, well, yes, cool mist was really helpful, or a steamy bathroom is really helpful. Some doctors will say, okay, oh, it's a winter time, okay, take your baby out for a ride, and that will help you because that exposure to cool air will soothe the cough and the throat. And the same thing, you can, put the hot water on in the bathroom and let the child breathe the steamy bathroom. And sometimes some providers I have heard saying that, okay, open your refrigerator and let the child, stand near the refrigerator so that cold mist will soothe in it. But even though there is no evidence, it is helpful, and most parents will agree to that. Then if the child is discharged on medications, instruct parents on importance of proper administration and dosage, and instruct parent on symptoms of potential medication side effects and on the symptoms of worsening conditions like increased signs of respiratory distress, restlessness, and confusion. Otitis media. It is suppurative infection of the middle ear cavity, and the signs and symptoms include in the acute otitis media, otalgia, that is acute ear pain, irritability, otorrhea, fever which may be high as 104 degree Fahrenheit, poor feeding, and rubbing or pulling at the affected ear. When the babies are like infants, they cannot talk, they cannot express. So the mothers will say, oh, there was a fever and the baby started rubbing and pulling the ear. So that is an indication that, oh yeah, there could be a possibility of otitis media. Then bulging of tympanic membrane, air fluid level or visualization of purulent material on otoscopic examination, post-auricular and cervical lymph glands and lymph node enlargement, otitis media with effusion or chronic otitis media, often asymmetrical and afebrile, and intermittent complaints of ear pain, feeling of fullness in the ear and popping or a feeling of talking in a barrel, complaint of hearing loss, dizziness or impaired balance, chronic vomiting, and failure to thrive may be related to chronic otitis media with effusion. Diagnosis is based on signs and symptoms and otoscopic examination. In acute otitis media, the intact membrane appears bright red and bulging with no visible landmarks or light reflex when you do the otoscopic examination. And in otitis media with effusion, the otoscopic examination reveals slightly injected dull gray membrane with obscured landmarks and visible fluid level or meniscus behind the eardrum if air is present. The management is control fever and pain with either acetaminophen or ibuprofen. But remember, do not use ibuprofen less than 6 months of age, and warm compress to affected ear. Treat infection with antibiotic. The most common medication used is amoxicillin. And one thing is recommended by American Academy of Pediatrics is watchful waiting. You must have heard about that. And this is like most of the time, otitis media, even if you do not treat, is self-resolving. But this watchful waiting is not treating for 24 to 48 hours. But this cannot be done in children less than 6 months. If the child is less than 6 months, then you need to treat with antibiotic, and the most common medication is amoxicillin. And if the child is over 6 months, then with the parent's consent, and you need to discuss and come to an agreement that, okay, if there is no worsening of the condition, and if it is getting better, do not treat. And if there is worsening of the condition in 24 hours to 48 hours, then treat with antibiotic. But we have to come to a mutual agreement between the parents and the provider. Next is surgical insertion of pressure equalizing tubes. Remains a common treatment for persistent otitis media with effusion. Education and discharge instructions. If antibiotics are prescribed, the full course of medication must be administered. And tell parents that if the child doesn't respond to antibiotics within 48 to 72 hours, another assessment must be done to confirm acute otitis media and exclude other causes of illness or ineffective antibiotic response. So if there is no improvement within 48 to 72 hours, you may have to change the antibiotic you are prescribed to. Gastrointestinal conditions, cleft lip, cleft palate, or both. Cleft lip is a failure of embryonic structure surrounding the oral cavity to join, and cleft palate is the failure of palatal shelves to fuse. It is a multifactorial congenital defect, genetic, more common in cleft lip than the palate, and environmental predispositions are there. Increase in middle ear or nasopharyngeal sinus infections with associated hearing loss is common with cleft lip and palate. There is a possibility of recurrent otitis media. The signs and symptoms are separation of lip and or palate, unilateral or bilateral cleft lip, can occur with or without cleft of the hard and or the soft palate, and both or either of the palates can have cleft without lip affected, and uvula can also contain cleft. Nursing care include maintaining adequate nutrition, breastfeeding possible but may be interrupted for a period of time based on the need for surgical repair. Bottle feeding is initiated with special nipples that is longer than a regular nipple to help prevent aspiration. Feed in upright position to decrease the incidence of regurgitation. Education and discharge instructions include explain all the treatments, feeding methods, and care measures to parents. Provide emotional support. Hypertrophic pyloric stenosis. It is obstruction due to thickening of circular muscle of the pylorus. The etiology is unknown. Suggested causal theories include a deficiency in inhibitory neuronal signals or molecular causes. And ganglionic cell immaturity has also been suggested as a causative factor. Signs and symptoms include a pattern of normal feeding and new onset of non-bilious vomiting. Remember that. And vomiting usually begins with episodes of regurgitation during first few weeks of life. Another practical point I want to tell you is, as a physical finding, you will see visible peristaltic waves progressing from left to right across the abdomen. So you may see the provider may perform a test like in a darkened room, shine a bright light on abdomen of a naked supine baby and feed a bottle of sugar water, and the peristaltic waves will be visible in pyloric stenosis. And vomiting usually occurs immediately after feeding and may become projectile. Infants generally appears hungry immediately after vomiting and eagerly wants to feed again. The diagnosis is by palpating a pyloric mass. It is otherwise known as olive-shaped mass. It is a classical sign. Olive-shaped mass is palpated, and abdominal X-ray and ultrasound is done, and confirmation by upper GI series demonstrate a string sign, which is caused by barium passing through a narrowed pylorus. The management of hypertrophic pyloric stenosis is by surgery. So the nursing care involves preoperative and postoperative care, as is dehydration, changes in vital signs, weight loss, discomfort. Education and discharge instructions include care of incision and observation for signs of infection, observe infant's response to feedings, as some vomiting may still occur within first 48 hours postoperatively. And vomiting beyond 48 hours must be reported to the child's healthcare provider. The next topic we will discuss is intussusception. It is one portion of the intestine invaginates or telescopes into another portion, and most commonly at the ileocecal valve. The signs and symptoms are acute abdominal pain caused by spasm of telescoping bowel. And pain frequently mimics pain experienced by colicky infants, so we have to be careful with that. Infants may pull their legs up towards the abdomen. That is something with intussusception, little classic about that. Diagnosis of intussusception based on history of characteristic symptoms and physical findings during examination, and presence of a sausage-shaped mass in the right upper quadrant. So I forgot to tell you that in pyloric stenosis, the olive-shaped mass is also felt in the right upper quadrant. In intussusception, it is a sausage-shaped mass. That is the difference between them when you do a physical examination. The nursing care include barium or air enema to reduce the intussusception. Surgery is another possibility. Then you will be performing preoperative and postoperative care. Watch for signs and symptoms of perforation. Education and discharge instructions include care of incision, observation for signs of infection, teach feedings, dehydration, and pain management. Hirschsprung's disease, otherwise known as congenital aganglionic megacolon. The absence of ganglionic cells results in lack of motility in the affected portions of the bowel. And the signs and symptoms include failure to pass meconium within the first 48 hours of life, failure to thrive, poor feeding, chronic constipation, vomiting, abdominal obstruction. The diagnosis is made by X-ray evidence of dilated loop of bowel, barium enema, and biopsy. Hirschsprung's disease is managed by surgery. So the nursing care includes preoperative and postoperative care. Keep the child NPO, feed, and in the later period, in the postoperative period, feed by nasogastric tube. Education and discharge instructions include care of temporary colostomy, because there will be a colostomy first, then after some time they will do the pull-through procedure and connect them back. And so the parents need to know the care of temporary colostomy and teach about symptoms of complications. And that is about this week's topic, and thank you for listening.